Hello, dear student. I hope you're okay and waiting for today's lecture. So let's start. And topic for today is chronic diseases of the small intestine, chronic diseases of the large intestine, irritable bowel syndrome, and non-specific colitis. So start with small intestine and celiac disease and Whipple disease. So some information about small intestine anatomy. And the small intestine lies between the stomach and the large intestine and includes the duodenum, jejunum, and ileum. The small intestine is so called because its lumen diameter is smaller than that of the large intestine, although it is longer in length than the large intestine. So the duodenum continues into the jejunum and the duodenal-jejunal junction of flexure, which lies to the left of the lumbar two vertebra and is fixed to the retroperitoneum by a supervisory ligament of Trace. The inferior mesenteric vein, IMV, lies to the left of the duodenum-jejunal junction. There are several peritoneal fossa around the duodenal-jejunal flexure, which measure the size of the internal herniation of the small bowel. The rest of the small intestine is a 4-6 meter long convoluted tube occupying the center of the abdomen and the pelvis, surrounded on two sides and above by the colon. The ileum continues into the large intestine and the ileocecal junction. The small intestine is differentiated from the large intestine by the presence of mesentery and the absence of the tenia coli and appendicitis epiploids, which are present in the colon. The demarcation between the jejunum and ileum is not very clear. And you may see on this slide a picture with anatomy of small intestine. And continue about function. The main function of the small intestine are secretion and absorption. The epithelial cells of the small intestine secrete enzymes which digest heme in the smallest particles, making them available for absorption. Concurrently, the duodenum functions to mix food with the bile and pancreatic enzymes to continue the digestion of the carbohydrates, fats, and proteins. Concerning absorption, carbohydrates and proteins are absorbed in the duodenum and jejunum respectively. The jejunum also functions to absorb most fats. The ileum function involves absorption of vitamin B12, bile salts, and all digestion products which were not absorbed in duodenum and jejunum. All three small intestine segments absorb water and electrolytes. So, details about celiac disease. Celiac disease is common cause of malabsorption of one or more nutrients, also known celiac sprue or gluten-sensitive enteropathy, is a chronic disorder of the digestive tract. The result inability to tolerance gliadin, the alcohol-soluble fraction of gluten. Gluten is a protein commonly found is wheat, rye, and barley. Most patients with celiac disease tolerate oats, but they should be monitored closely. When people with celiac disease ingest gliadin, the mucosa of the intestine is damaged by immunologically mediated inflammatory response, resulting in maldigestion and malabsorption. Celiac disease results from a combination of immunological responses to an environmental factor, gliadin, and several genetic factors. So what about genetic factor? Genetic play an important role in celiac disease. The incidence of celiac disease in relatives of patients with celiac disease is significantly higher than in the general population. The prevalence is first-degree relative of patients with celiac disease is approximately 10%. Concordance for the disease in monozygotic twins approaches 75% and is of approximately 30% for first-degree relative. Details about immune mechanism. The interaction of alcohol-soluble gliadin in wheat, barley, and rye with the mucosa of the small intestine is crucial to the pathogenesis of celiac disease. Endogenous tissue transglutaminase deimitates glutamine in gliadin, converting it from a neutral to negatively charged protein. Negatively charged gliadin has been shown to induce interleukin-15 in the enteric epithelial cells, stimulating the proliferation of the natural killer cells. Gliadin can produce symptoms and the histological change in the small intestine when administered to patients with asymptomatic celiac disease. Anti-gliadin antibodies can frequently be identified in untreated patients. Immunoglobulin A antibodies to smooth muscles, endomyosine, and tissue transglutaminase are used for serological diagnosis. However, 3–5% of all patients with celiac disease are immunoglobulin A deficient. Therefore, determine total immunoglobulin A to antibody testing is appropriate in patients with celiac disease. And pathophysiology. A strong association exists between celiac disease and two human leukocytes antigen, antigen HLA, haplotypes DQ2 and DQ8. Damage to the small intestinal mucosa occurs with the presentation of gluten-derived peptide gliadin consisting of 33 amino acids by the HLA molecules to helper T cells. Helper T cells mediate the inflammatory response. Endogenous tissue transglutaminase deimitates gliadin into a negatively charged protein, increasing its immunogenicity. Antibodies to type 2 transglutaminase is a hallmark of celiac disease. Absence of intestinal villi and lengthening of the intestinal crypts characterize the mucosal lesions in untreated celiac disease. More lymphocytes infiltrate the epithelium. Destruction of the absorptive surface of the intestine leads to a maldigestion and malabsorption syndromes. The hallmark of celiac disease is abnormal small intestinal biopsy as a response of the condition to the elimination of gluten from the diet. The histological chains have a proximal to distal intestinal distribution of severity, which probably reflects the exposure of the intestinal mucosa to varied amounts of dietary gluten. And pathophysiology of diarrhea. The diarrhea celiac disease have several pathogenetic mechanisms. Diarrhea may be secondary to steatorrhea, which is primary result of change in the immune mucosal function, secondary lactase deficiency and consequence of change in the urinary brush body enzymatic function. Next, bile acid malabsorption resulting in bile acid-induced fluid secretion in the colon. And next, endogenous fluid secretion resulting from crypt hyperplasia. And history and manifestation. And the manifestation of untreated celiac disease can be divided into gastrointestinal symptoms and extra-intestinal symptoms. So, about gastrointestinal symptoms, diarrhea is the most common symptom in untreated celiac disease, and it present in 85% of all patients. Diarrhea caused by celiac disease is due to the maldigestion and malabsorption of nutrients. The stools might be watery or semi-formed, light tan or gray and oily or frothy. The stools have a characteristic foul odor. In infants and young children, extensive diarrhea can lead to severe dehydration, electrolyte depletion, and metabolic acidosis. Next, symptom malabsorption of ingested fat. A result is the delivery of the excessive dietary fat to the large bowel. Next, symptoms flatulence and borborygmus result from the release of gas by the intestinal bacterial flora feasting on the undigested and unabsorbed food materials and often becomes excessive and even explosive. Next symptoms, weight loss. Invariable because some patients might compensate for the malabsorption by increasing their dietary intake. Next symptoms, weakness and fatigue, are usually related to the general poor nutrition. In some patients, severe anemia can contribute to fatigue. And next, symptoms, severe abdominal pain, unusual in patients with uncomplicated celiac disease. However, abdominal bloating or cramps with excessive malodorous floaters is a common complaint. And extra-intestinal symptoms. Anemia is usually due to the impaired absorption of iron on folate from the proximal small intestine. Next, osteopenia and osteoporosis may develop for several reasons, including defective calcium transport by the diseased small intestine, vitamin D deficiency, and binding of luminal calcium and magnesium to the unabsorbed dietary fatty acids. Neurological symptoms that result from hypocalcemia include motor weakness, paresthesias with sensory loss, and ataxia. Skin disorders, including dermatitis herpetiformis, is associated in 10–20% of patients with celiac disease, and hormonal disorders such as amenorrhea, delayed menarche, and infertility in women and impotence and infertility in men have been described. physical examination, finding may relieve the following. Abdominal examination shows a protuberant and tympanic abdomen due to the distension of the intestinal loops with fluid and gas. Ascites occasionally can be detected in patients with severe hyperproteinemia. Evidence of weight loss included muscle wasting or loose skin fold, orthostatic hypotension, peripheral edema, ecchymosis, hyperkeratosis and dermatitis herpetiformis, halitosis and glossitis. Evidence of peripheral neuropathy, Hvostek sin and Trousseau sin. Diagnosis. A small intestinal biopsy is required to establish a diagnosis of celiac disease. A biopsy should be performed when patients have symptoms and laboratory findings suggestive of nutrient malabsorption and or deficiency, as well as a positive TTG antibody test. Without overt evidence of malabsorption or nutrient deficiency, a relatively low threshold for biopsy performance is important. And treatment approach. First of all, diet. The primary management of celiac disease is dietary, but research into novel non-dietary therapy is ongoing. Complete elimination of gluten-containing grain products is essential to treatment. Although the majority of patients will celiac disease respond to a gluten-free diet, persistent or recurrent symptoms affect up to 20%. After an initial period of avoidance, oats might be reintroduced into the diet of patients with celiac disease. These patients should be monitored carefully for recurrent symptoms. Careful and extensive indoctrination of the patient by the physician and the dietarian is often necessary to achieve full compliance. Next approach is corticosteroids. A small percent of patients with celiac disease fail to respond to a gluten-free diet. In some patients who are refractory, corticosteroid might be helpful. In patients who fail to respond to corticosteroid, other comorbid conditions such as lymphoma of the small intestine have to be ruled out. And next disease of small intestine is Whipple disease. Whipple disease is a chronic multisystemic disease associated with diarrhea, steatorrhea, weight loss, arthralgia, and central nervous system and cardiac problem. Most likely caused by a gram-positive bacterium, Troponema Whipple. Of note, patients with human immunodeficiency virus infection do not acquire the disease. Whipple disease is extremely rare worldwide. Only several hundred clinical cases have been reported, mostly from North America and Western Europe. The disease appears to be associated with a human leukocyte antigen B27 haplotype. Whipple disease is most common in white males and rarely is described in females. The route of disease transmission is not known, but may be associated with occupational exposure to animals and soil. Pathophysiology of Whipple disease. The clinical manifestation of the disease are believed to be caused by infiltration of the various body tissue by T. Whipple. The patient immune system reacts by incorporating the organism into tissue macrophages. These macrophages can be easily observed infiltrating the tissues using conventional light microscope. The macrophages are easily observed when periodic acid sheep stain is used for the histologic section. The malabsorption observed in the small bowel that is associated with this condition is believed to be secondary to the disruption of normal venous function due to infiltration of the lamina propria of the small bowel. Patients with the arthralgia have been found to have the organism in the synovial tissues. The organisms have been detected in the short walls of patients with cardiac Whipple disease and in the central nervous system of patients with neurological disease. Rarely, the organism can be detected in the lung of affected patients. And clinical presentation. Whipple disease was first described by Dr. George Whipple in 1907, and the classical presentation of Whipple disease is that was Western illness characterized by arthralgia, arthritis, fever, and diarrhea. However, this form is rare. Lymphadenopathy may be present. If Whipple disease affects the small intestine, steatorrhea often is present. The onset of Whipple disease in insidious and is characterized by diarrhea, steatorrhea, abdominal pain, weight loss, migratory large arthropathy, and fever, as well as ophthalmological and central nervous system symptoms. Dementia is a relatively late symptom and an extremely poor prognostic sign, especially in patients who experience relapse after the induction of a permission with antibiotics. Approximately 90% of patients with Whipple disease present with weight loss and 70% of patients with Whipple disease complain of either diarrhea and arthralgia. It's about 3/4 of patients, the joint manifestations are followed by weight loss and diarrhea, with a mean time of 6 years from onset of the joint symptoms to diagnosis of Whipple disease. Occult gastrointestinal bleeding can be found in 80% of patients with Whipple disease, but frank hematochezia is uncommon. Cardiac involvement occurs in approximately 30% of cases. Diagnosis of Whipple disease is suggested by a multisystemic disease in a patient with diarrhea and steatorrhea, tissue biopsy of the small intestine, and or other organs that may be involved. Given the patient's symptoms is the primary approach. The presence of a PAS-positive macrophages containing the characteristic small bacilli is suggestive of this diagnosis. However, T. Whipple containing macrophages can be confused with PAS antibodies macrophages containing M. avarium complex, which may be cause of diarrhea is ADS. The presence of the T. Whipple bacillus outside of macrophages is a more important indicator of active disease than it is there present within the macrophages. Two people have shown been successfully grown in culture. And approach consideration. The mainstay of medical treatment for management on Whipple disease is antibiotic therapy. Surgery is not part of the therapy for Whipple disease. Once the diagnosis of Whipple disease is established and antibiotics are started, patient may be discharged for continued therapy as outpatient. Consultation with gastroenterologist, cardiologist, rheumatologist, orthopedist, and neurosurgeon may be necessary for obtaining the approach tissue biopsy in selected patient. What about outpatient monitoring? Patients with clinical Whipple disease should be monitored with a polymerase chain reaction because it's the most sensitive and specific method to determine if they are responding to antibiotic therapy. The Whipple has been detected through PCR is normal saliva, gastric juice, and intestinal tissue. The standard initial treatment regimen is either intravenous ceftriaxone 2 grams once daily, orally 2 million units of penicillin G every 4 hours, both for 15 days duration. After the initial treatment is completed, 1 year of maintenance therapy is with oral double strength trimethoprim sulfamethoxazole twice daily. And second part of this lecture is chronic disease of the large intestine and details about irritable bowel syndrome, IBS, and inflammatory bowel disease, IVT. So, some words about anatomy. So, the large intestine is approximately 1.5 meter long and comprises the cecum, colon, rectum, anal canal, and anus. The structure of the large intestine is very similar to that of the small intestine, except that its mucosa is completely devoid of villi. The cecum is about 6 centimeters long and extends downwards into the appendix and widening tubular subcutaneous lymphoid tissue. The appendix is thought to be the vestige of the redundant organ. It is narrow and twisted shape marks in the attractive site for the accumulation and multiplication of intestinal bacteria. Food residue starts by traveling upwards through the ascending colon located on the right side of the abdomen. The ascending colon bends near the liver of the right colic flexure and becomes the transverse colon, passing across to the left side of the abdomen. Just above the spleen and the left colic flexure, the transverse colon becomes the descending colon, which run down the left side of the abdomen. Before the next bend, the descending colon transforms in the sigmoid colon. The ascending colon, descending colon, and rectum are located in the retroperitoneum. The transverse and sigmoid colon are attached to the posterior abdominal wall by the mesocolon. Distally, the large intestine opens into the rectum, which is continued by the anal canal. The rectum forms the final 20 centimeters of the gastrointestinal tract. It is continuous with the sigmoid colon and connects with the anal canal and anus. And function of colon. The large intestine has three major functions: absorption of water and electrolytes, formation and transport on feces, chemical digestion by gut microbes. And detail about irritable bowel syndrome, IBS, is defined as recurrent abdominal pain on average at least 1 day per week in the last 3 months, with 2 or more of following: related to defecation, associated with a change in frequency of stool, or associated with a change in form of stool. Irritable bowel syndrome is a chronic function disorder on the gastrointestinal tract and characterized by chronic abdominal pain and altered bowel habits in the absence of the organic disease. Irritable bowel syndrome is the most common reason to visit a gastroenterologist and the second most common reason after common flu to be absent from work. The Rome 4 criteria for diagnosis of irritable bowel syndrome requires that patient have been recurrent abdominal pain on average at least 1 day per week during the previous 3 months and associated with 2 or more of the following: related to defecation, associated with a change in stool frequency, associated with a change in stool form or appearance. And classification, irritable bowel syndrome, and what will be with predominant constipation, with predominant diarrhea, and mixed or combined two variant diarrhea and constipation. And maybe unclassified variant. And some words about pathophysiology. Traditional theories regarding the pathophysiology of irritable bowel syndrome may be visualized as a three-part complex of altered gastrointestinal tract motility, visceral hyperalgesia, and psychopathology. More recently, it is believed that components of the gut microbiota potentially influence brain morphology and function, behavior, and cognition, which expand the paradigm of the gut-brain axis. Clinical presentation. Constipation results in complaint of hard stools of narrow caliber, painful on infrequent defecation, intractability to laxatives. Diarrhea usually is decreased as small volumes of loose stool with evacuation preceded by urgency or frequent defecation. Postprandial urgency is common, as is alternation between constipation and diarrhea. What next symptoms is abdominal pain. The description are protean. Pain frequently diffuse without irradiation. Common sites of pain include the lower abdomen, specifically the left lower quadrant. Acute episodes of sharp pain are often superimposed of a more constant dull ache. Meals may be precipitate pain, and defecation commonly improves pain. Defecation may not fully relieve pain, however. Pain from presumed gas pocket in the splenic plexus may masquerade as anterior chest pain or left upper quadrant abdominal pain. Next symptoms: abdominal bloating or distension. Patients frequently report increased amount of bloating and gas. Coincidentally, measurements fail to support this claim. People with irritable bowel syndrome may manifest increase in abdominal circumference throughout the day as assessed by computer tomography scan. Symptoms not consistent with irritable bowel syndrome should be alert the clinician the possibility of an organic pathology. Inconsistent symptoms include the following: onset in middle or older age, acute symptom, progressive symptoms, nocturnal symptoms, anorexia or weight loss, fever, rectal bleeding, painless diarrhea, cyarrhea, gluten intolerance. And approach consideration. Management of irritable bowel syndrome consists primarily of providing psychological support and recommending dietary measures. Pharmacological treatments is adjuvantive and should be directed at symptoms such as modulation of persistent visceral hyperalgesia. In 2009, American College of Gastroenterologists position statement concluded that psychological intervention, cognitive behavior therapy, dynamic psychotherapy, and hypnotherapy are more effective than placebo. Frequent visit with the clinician enhance the patient-provider relationship, especially in patients who were recently diagnosed with irritable bowel syndrome. Visits can become less frequent as patients are educated and reassured. Agents used for the management of symptoms in irritable bowel syndrome include anticholinergic, antidiarrheals, tricyclic antidepressants, prokinetic agents, book-forming lactives, serotonin receptor antagonist, chloride channel activator, and guanylate cyclase C agonists. And next disease is inflammatory bowel disease. IVD is an idiopathic disease caused by dysregulated immune response to host intestinal microflora. The two major types of inflammatory bowel disease are ulcerative colitis, UC, which is limited to the colonic mucosa, and Crohn disease, CD, which can affect any segment of the gastrointestinal tract from the mouth of the anus, involves skip lesion, and is transmural. Etiology of inflammatory bowel disease. The characteristic defines the etiology. Genetic predisposition, an altered dysregulated immune response, and altered response to gut microorganisms. History of inflammatory bowel disease. The manifestation of this disease generally depends on the area of the intestinal tract involved. The commonly experienced symptoms of Crohn disease include recurrent abdominal pain and diarrhea. Sometimes the diagnosis may be delayed by several months to a few years, and these symptoms are not specific for inflammatory bowel disease. Patients with this disease may have symptoms of irritable bowel syndrome with cramping, irregular bowel habits, and passage of mucosa without blood or pus. Systemic symptoms are common in inflammatory bowel disease and include weight loss, fever, sweats, malaise, and arthralgia. A low-grade fever may be the first warning sign of a flare. Patients are commonly fatigued, which is often related to the pain, inflammation, and anemia that accompany disease activity. Recurrences may occur with emotional stress, infection, or other acute illnesses, pregnancy, dietary problems, use of cathartic of antibiotics, on adherence to therapy. And continue about manifestation, about symptoms, and the word gastroenterology organization indicated the following symptoms may be associated with inflammatory damage in the digestive tract: diarrhea, constipation, bowel movement abnormalities, abdominal cramping and pain, nausea, vomiting. So, details about non-specific ulcerative colitis. Ulcerative colitis has first described in 1875 by two English physicians, Wilkes and Moxon, who distinguished it from diarrheal diseases caused by infectious agents. Pathophysiology of ulcerative colitis. The common end pathway of ulcerative colitis is inflammation of the mucosa of the intestinal tract, causing ulceration, edema, bleeding, and fluid and electrolytes loss. In several studies, genetic factors appear to influence the risk of inflammatory bowel disease by causing a disruption of epithelial barrier integrity deficits in autophagy, deficiencies in innate pattern recognition receptor, and problem with lymphocyte differentiation, especially in Crohn disease. Inflammatory mediators have been identified in inflammatory bowel disease, and considerable evidence suggests by these mediators play an important role in the pathologic and clinical characteristics of these disorders. Cytokines, which are released by macrophages in response to various antigenetic stimuli, bind to different receptors and produce autocrine, paracrine, and endocrine effects. Cytokines differentiate lymphocytes into different types of T cells. In ulcerative colitis, the inflammation begins in the rectum and extends proximally in an interrupted fashion to the proximal colon and could eventually involve the entire length of the large intestine. Signs and symptoms. The mild symptoms of ulcerative colitis are diarrhea, rectal bleeding, tenesmus, passage of mucus, and crampy abdominal pain. The severity of symptoms correlates with the extent of disease. Although ulcerative colitis can present acutely, symptoms usually heavy presence for weeks to months. Occasionally, diarrhea and bleeding are so intermittent and mild that the patient does not seek medical attention. Laboratory, endoscopic, and radiographic feature. Active disease can be associated with a rise in acute phase reactants, platelets count, and erythrocyte sedimentation rate, and decrease in hemoglobin. Fecal lactoferrin and glycoprotein presence in activated neutrophils is a highly sensitive and specific marker for the detecting essential inflammation. Fecal calprotectin protectin is present in neutrophils and monocytes, and levels correlate well with histological inflammation, predict relapses, and detect pathogens. Both fecal lactoferrin and calprotectin are becoming an integral part of inflammatory bowel disease management and are used frequently to rule out active inflammation versus symptoms of irritable bowel or bacterial overgrowth. In severely ill patient, the serum albumin level will fall rising quickly. Leukocytosis may be present but is not a specific indicator of disease activity. Proctitis or proctosigmoiditis causes a rise in CRP, C-reactive protein. And about examination, about laboratory, endoscopic, and radiographic features. What provide? Sigmoidoscopy is used to assess disease activity and is usually performed before treatment. If the patient is not having an acute flare, colonoscopy is used to assess disease extent and activity. Endoscopically, mild disease is characterized by erythema, decreased vascular pattern, and mild friability. Moderate disease is characterized by marked erythema, absence vascular pain, friability, and erosions, and severe disease by spontaneous bleeding and ulcerations. And Crohn disease. Crohn disease was first described in 1932 by three doctors, Burial Crohn, Leon Zingberg, and Gordon D. Oppenheimer. At the time, any disease in small intestine was thought to be intestinal tuberculosis. Crohn disease can affect any portion of the gastrointestinal tract from the mouth to the anus and causes a three pattern of involvement: inflammatory disease, strictures, and fistula. This disease consists of segmental involvements by a non-specific granulomatous inflammatory process. The most important pathologic feature of Crohn disease is that it's transmural, involving all layers of the bowel, not just the mucosa and the submucosa, which is characteristic of ulcerative colitis. Furthermore, Crohn disease is discontinuous, with key areas interspersed between two or more involved areas. Late in the disease, the mucosa develops a cobblestone appearance, which results from deep longitudinal ulceration interlaced with the intervening normal mucosa. Diarrhea, cramp, and abdominal pain are common symptoms of Crohn disease in the all above location, except for the gastrointestinal region, in which anorexia, nausea, vomiting, are more common. Rectal swelling is a typical but non-constant feature of Crohn disease. However, unrectal complications are common. Much less commonly, Crohn disease involves a more proximal part of the gastrointestinal tract, including the mouth, tongue, esophagus, stomach, duodenum. The incidence of gallstones, the kidney stone, is increased in Crohn disease because of malabsorption of fat and bile cells. Gallstones are formed because of increased cholesterol concentration in the bile, which is caused by reduced bile salt pool. And signs and symptoms. And what about manifestation? And the main symptoms, main manifestation is ileocolitis. What is it? Because the most common site of inflammation is a terminal ileum, the usual presentation of ileocolitis is a chronic history of recurrent episodes of right lower quadrant pain and diarrhea. Sometimes this initial presentation mimics acute appendicitis with pronounced right lower quadrant pain, a palpable mass, fever, and leukocytes. Pain, usually colicky, is preceded either relieved by defecation. An inflammatory mass may be palpated in the right lower quadrant of the abdomen, is composed of inflamed bowel, induration of the mesentery, and enlarged abdominal lymph nodes. Extension of the mass can cause obstruction of the right ureter or bladder inflammation, manifested by dysuria and fever. The string site of barium studies result from a severely narrowed loop of bowel, which makes the lumen resemble a friar cotton string. It is caused by incomplete filling of the lumen and the result of edema, irritability, and spasm associated with inflammation and ulceration. The scene may be seen is both non-stenotic and stenotic phases of disease. Next symptoms, ileitis. Extensive inflammatory disease associated with a loose digestive and absorptive surface resulting in malabsorption and steatorrhea. Nutritional deficiencies can be also result from poor intake and enteric losses of protein and other nutrients. Intestinal malabsorption can use anemia, hypoalbuminemia, hypocalcemia, hypomagnesemia, coagulopathy, hyperoxaluria with nephrolithiasis in patients with an intact colon. Many patients need to take oral and often intravenous iron. Vertebral fracture and are caused by a combination of vitamin D deficiency, hypocalcemia, and prolonged glucocorticoid use. Pellagra from niacin deficiency can occur in extensive small bowel disease, and malabsorption of vitamin B12 can lead to megaloblastic anemia and neurological symptoms. Other important nutrients to measure and replete is low in folate and vitamin A, E, K. Level of minerals such as zinc, selenium, copper, and magnesium are often low in patients with extensive small bowel inflammation on resection, and they should be repleted as well. Most patients should be taking daily multivitamin, calcium, and vitamin D supplements. Diarrhea is characteristic of an active disease. Its causes include first, bacterial overgrowth in obstructive stages or fistulization. Second, bile acid malabsorption due to diseases of resecting terminal ileum. And third, intestinal inflammation with decreased water absorption and increased secretion of electrolytes. And some words about colitis and perianal disease. Patients with colitis present with low-grade fever, malaise, diarrhea, cramped abdominal pain, and sometimes hematochezia. Gross bleeding is not as common as in ulcerative colitis and appears in about one-half of patients with exclusively colonic disease. So some words about examination, laboratory, endoscopic, radiographic feature. Laboratory study results are generally non-specific, but may be helpful in supporting the diagnosis and management of the disease. Serological studies are sometimes used to facilitate differentiation of Crohn disease from ulcerative colitis or inflammatory of in undetermined type. And capsule endoscopy is sensitive for early mucosal inflammation, but it can only detect mucosal change, whereas MRI and intestinal ultrasonography are able to relieve transmural inflammation as well as identify complications. Ultrasonography, computer graphics, scanning, and MRI can determine pre-treatment and post-treatment disease activity or identify disease complication. Endoscopic feature of Crohn disease include rectal sparing, afterwards ulceration, fistulas, and skip lesion. Plain radiography or computer tomography scanning of the abdomen can be used to assess bowel obstruction. The studies can also be used to assess the pelvis for the presence of any intra-abdominal abscesses. And extra-intestinal manifestation of inflammatory bowel disease. Dermatological. For example, erythema nodosum occurs in up to 15% of Crohn disease patients and 10% of ulcerative colitis patients. Next, pyoderma gangrenosum is seen in 1–12% of ulcerative colitis patients and less commonly in Crohn colitis. Other dermatological manifestations include pyoderma vegetans, which occurs in intertriginous areas, pyostomatosis vegetans, which involves the mucous membrane, Sweet syndrome, and neutrophilic dermatosis, and metastatic Crohn disease, a rare disorders defined by cutaneous granuloma formation. Psoriasis affect 5–10% of patients with inflammatory bowel disease and is unrelated to bowel activity consistent with a potential shared immunogenetic basis of the diseases. Rheumatological symptoms of disease, for example, peripheral arthritis. Development is 15–20% of inflammatory bowel disease patient is more common in Crohn disease and worsens with exacerbations of bowel activity. Next rheumatological manifestation, ankylosing spondylitis, occurs in about 10% of inflammatory bowel disease patient and more common in Crohn disease than ulcerative colitis. Next manifestation, sacroiliitis, is symmetric, occurs equally in colitis and Crohn disease, is often asymptomatic, doesn't correlate with bowel activity, and doesn't always progress to ankylosing spondylitis. Hepatobiliary manifestation. Hepatic stenosis is detectable in about 1/2 of the normal liver biopsies for patients with Crohn disease and colitis. Patient usually present with hepatomegaly. Next, primary sclerosing cholangitis is a disorder characterized by both intrahepatic and extrahepatic bile duct inflammation and fibrosis, frequently leading to biliary cirrhosis and hepatic failure. 5% of patients with colitis have primary sclerosing cholangitis, but 75% of patients with this cholangitis have inflammatory bowel disease. Gallbladder polyps in patients with cholangitis have a high incidence of malignancy, and cholecystectomy is recommended, even if the mass lesion is less than 1 centimeter in diameter. Next manifestation, ocular and urologic. The incidence of ocular complication in inflammatory bowel disease patient in 1–10%. The most common are conjunctivitis, anterior uveitis and iritis, and episcleritis. The most frequent genitourinary complications are calculi, ureteral obstruction, and ileal bladder fistula. And treatment on bowel disease. Treatment is made on the basis of the disease site, pattern, activity, and severity. The general goals of treatment are followed: to achieve the best possible clinical, laboratory, and histological control of the inflammatory disease with the least adverse effect from medication, to permit the patient to function as normally as possible, in general to promote growth with adequate nutrition. And first drugs is 5 SA agents. These agents are effective including and maintain remission in ulcerative colitis. They may have a limited road-inducing remission in Crohn disease, but no clear rule in maintenance of Crohn disease. Newer sulfa-3 aminosalicylate preparations deliver increased amount of the pharmacological active ingredient of sulfasalazine to the site of the active bowel disease while limiting systemic toxicity. And there are 4 main 5-amino salicylic acid drugs: balsalazine, mesalamine, osalazine, and sulfasalazine. Aminosalicylates can reduce leukotriene production and can inhibit the cellular release of an interleukin-1, all of which are likely to be important in reducing the acute inflammatory response in inflammatory bowel disease. Next drugs are glucocorticosteroids. The majority of patients with moderate to severe ulcerative colitis benefits from oral or parenteral glucocorticosteroid. Prednisolone is usually started at dose of 40–60 mg a day for active ulcerative colitis that is unresponsive to 5-ASA therapy. Next, drugs, antibiotics. Antibiotics have no role in the treatment of active ulcerative colitis, usually respond to treatment with metronidazole and/or ciprofloxacin. Metronidazole is active inflammatory, fistulizing, and perianal Crohn disease and may prevent recurrence after ileal resection. The most effective dose is 15-20 milligram a kilogram per day. Three divided doses is usually continued for several months. And ciprofloxacin 500 milligram is also beneficial for inflammatory, perianal, and fistulizing Crohn disease, but has been associated with tendinitis and tendon rupture. Next, drugs azathioprine and 6-mercaptopurine and methotrexate. Azathioprine and 6-mercaptopurine are purine analyzed used concomitantly with biologic therapy or less often as a sole immunosuppressant. Azathioprine is rapidly absorbed and converted to 6-AMP, which is then metabolized to the active end product thionosinic acid, an inhibitor of purine ribonucleotide synthesis and cell proliferation. And methotrexate inhibits dehydrofolate reduced, resulting in impaired DNA synthesis. Additional anti-inflammatory properties may be related to decrease in the production of interleukin-1. Next drugs, cyclosporine is a lipophilic peptide with inhibitory effects of both the cellular and human immune system. CA blocker the production of interleukin-2 by T helper lymphocytes. CA bind to cyclophilin, and this complex inhibits calcineurin, a cytoplasmic phosphatase enzyme involved in the activation on T cells. CA also indirectly inhibits B cells function by blocking helper T cells. CA has a more rapid onset on action than 6-MP and azathioprine. And biological therapy is now commonly given an essential therapy for patients with moderate to severe chronic Crohn disease and ulcerative colitis. Patients who respond to biological therapy enjoy an improvement in clinical symptoms, a better quality of life, less disability, fatigue, depression, and severe surgeries and hospitalization. And what is drugs? Anti-TNF-alpha, anti-integrin, anti-interleukin 12, and anti-interleukin 23. And different drugs, for colitis and Crohn disease. An anti-TNF therapy, biological therapy. AK, inflammatory, cytokine and mediator for intestinal inflammatory, is impressed prominently in inflammatory bowel disease. Patients likely to benefit from anti-tumor necrosis factor therapy include the following. Patient who has moderate to severe debilitating symptoms of Crohn disease, who have documented active inflammation, or who are dependent on corticosteroid and unable to taper this agent without return of symptoms, and patients who do not show evidence to active bowel infection as a cause of gastrointestinal symptoms. And some Words about anti-integrins. Integrins are expressed on the cell surface of leukocytes and serve as a mediator of leukocyte adhesion, vascular endothelium alpha for integrin along with its beta-1 and beta-7 subunit interact with endothelial ligands termed adhesion molecules. Interaction between alpha 4 beta 7 and mucosal adhesion, cellular adhesion molecular is important is lymphocyte trafficking to gut mucosa. And what name of integrins? Natalizumab, vedolizumab, ustekinumab. And pharmacological treatment for diarrhea. Diarrhea may be developed as a result of active disease. Other possible causes include acute infection, bacterial overgrowth, loss of ileocecal valve, short bowel syndrome, lactase deficiency, concomitant celiac disease, and functional bowel disease. Chronic diarrhea in Crohn disease responds well to antidiarrheal agents such as loperamide, bile acid binders, diphenoxylate with atropine, and tincture of opium. Such agents should be considered with care in active colitis because of the risk of toxic megacolon. And surgical treatment. Nearly 1/2 patients with extensive chronic colitis undergo surgery within the first 10 years of their illness. Because colitis is a mucosal disease, the rectal mucosa can be dissected and removed down to the dentine line of the anus or about 2 cm proximal to this landmark. The ileum is fashionated into a pouch that serves as a neorectum. Most patients with Crohn's disease require at least one operation in their lifetime. The need to surgery is related to duration of disease and the site of the involvement. Patients with small bowel disease have an 80% chance of requiring surgery. Those with collagen alone has a 50% chance. Surgery is an option only when medical treatment has failed on complication dictate its necessity. And on the left, you may see table for the with indication for surgery for ulcerative colitis and Crohn's disease. So please read and remember these indications. And complication of bowel disease may be intestinal complication and extra intestinal complication. What is intestinal complication? Associated with several gastrointestinal complications, including hemorrhage, perforation, stricture, fistula, as well as perianal disease and related complications, such as perianal and pelvic abscesses, toxic megacolon, and malignancy. And some words about extrastinal complication. What may be? These include osteoporosis, hypercoagulability resulting in venous thromboembolism, anemia, gallstones, primary sclerosing cholangitis, aphthous ulcers, arthritis, uritis, episcleritis, and skin complication. So, dear student, thank you for your attention. I hope you have interest for this lecture and see you on next week with new lecture for you. Good luck and goodbye.